Hello again, I'm Harris Carmichael, and in this episode we're going to focus on hematology and oncology physiology. The A, B, AB, and O designations refer specifically to what antigens a person's red blood cells express. So on the surface of your RBCs, you can express either A, B, both A and B, or neither, which is called type O. A person will naturally develop antibodies against surface antigen types that they do not have. And why is that? In the hematology community, this is understood to be an immune reaction to similar antigens found on bacteria that closely mimic the ABO antigens. Basically, this is a cross-reaction similar to the pathophysiology of some autoimmune disorders, but importantly here, you will never make antibodies against your own antigen. For example, if you have type A blood, you will have anti-B antibodies. And the converse is also true if you have type B blood, you will have anti-A antibodies. Obviously, these won't react with your own antigen. If you have blood type AB, you won't have any ABO antibodies, because you have both antigens. And if you have blood type O, well, what antibodies do you predict you will have? That would be both anti-A and anti-B antibodies, and of course, these won't react with antigens that you don't have. These blood groups are why compatibility is so important when blood products are administered to patients. If you have a person with type B blood, and they are given a transfusion with type A blood, then the host anti-A antibodies are going to recognize the intruder and tell the immune system to react in a type 2 hypersensitivity. Do you recall from immunology why this is a type 2 hypersensitivity? That is because the reaction is occurring against an antigen on the surface of a cell. These hypersensitivity types pop up all over the place, and it's important for you to take the time to recognize each one because the USMLE will throw these hypersensitivity questions in every topic on your exam. This particular type 2 hypersensitivity is in poorly matched blood and is going to induce hemolysis and can continue its destruction, leading to possible renal failure, shock, and even death. So knowing all of this, which type of blood do you predict would be known as the universal recipient? That would be blood type AB, because these people don't have either type of antibody and cannot react against any type of antigen. Then which type would be known as the universal donor? That would be blood type O, because people with this type of antibody have neither type of antigen on their RBC surface, so no ABO antibodies are made against this cell. Another antigen that blood cells can express is the Rh antigen. RBCs either have an Rh antigen or they don't, so a person is either Rh positive or Rh negative. An important distinction between ABO antibodies and Rh antibodies is that while ABO antibodies are natural antibodies, meaning that all people will have them if they do not have the ABO antigen, Rh antibodies are not natural antibodies, and so an Rh negative person must be exposed to the Rh antigen before you would express the antibody. Also very important is that the ABO antibodies are IgM antibodies, while Rh antibodies are IgG antibodies. This is extremely important because IgM antibodies are too large to cross the placenta, and IgG antibodies can cross the placenta via the FcRn receptor. The Rh antigen is very important in the context of pregnancy, and the fact that they can cross the placenta is commonly tested on the boards in the following way. If a mother is Rh negative and has a fetus that received the Rh antigen from the father, so the father is Rh positive and the fetus is now also Rh positive, fetal blood will normally enter the maternal bloodstream during pregnancy and delivery, and the mother will develop a strong Rh antibody titer. This does not affect the first child, as it takes time for the IgG titer to rise to a significant level. But subsequent Rh positive fetuses will be attacked by the mother's immune system, leading to hemolytic disease of the newborn, also known as erythroblastosis fetalis. To prevent erythroblastosis fetalis, an Rh negative mother is given a pharmacological Rh antibody called RhoGAM during every pregnancy and immediately after every delivery. The idea is that if any Rh positive cells or antigen does make it into the maternal bloodstream, this immunoglobulin will neutralize it or cover it up to conceal it from the mother's immune system. The idea is that if one of the mother's naive B cells just happens to have the right antibody on its surface and just happens to pass by with Rh antigen exposed and laying around, it could activate and start producing anti-Rh antibodies in mass quantities. ROGAM prevents this reaction from ever occurring. Let's try a quick flash quiz. What ABO blood type would be the universal donor for plasma? That would be type AB. When donating plasma, you have to think about the antibodies that would be in the plasma. Type AB would not have any antibodies, so they would be the universal donor of blood plasma. This means type O would be the universal recipient of plasma, because no matter the antibody in the plasma, it would not react against the host RBCs. Now we're going to tackle the coagulation and kinin pathways. This can be a daunting process at first glance, but it's really about breaking these massive diagrams into their individual components and then bringing everything together at the end. The three major components are the intrinsic pathway, the extrinsic pathway, and the common pathway. The job of both the intrinsic and extrinsic pathways is to help initiate and maintain coagulation. So they both have the same goal, and we'll start with the extrinsic pathway. This pathway starts with factor 7, which is activated by thromboplastin, or tissue factor. So when exposed to tissue factor, factor 7 is activated to 7A, and the small a next to a number just means activated. So 7A then goes on to activate factor 10, and factor 10 is the first step in the common pathway. So that's it. We're done. That's the extrinsic pathway. This is not only a much shorter pathway, but it is also a more important pathway in clot initiation, whereas intrinsic pathway is more important for clot amplification. To measure the function of the extrinsic pathway, you would follow a lab test called prothrombin time, or PT for short. The reason PT is a good measure for the extrinsic system specifically is that you begin the test by adding tissue factor, which will activate factor 7 to 7A and tell you the function of the extrinsic system and not the intrinsic pathway. The other test used to monitor the extrinsic pathway is the INR, which stands for International Normalized Ratio, and serves to normalize the PT measurement from laboratory to laboratory, as they were previously highly variable. Next up is the intrinsic pathway. The intrinsic pathway starts with factor 12. When factor 12 is exposed to collagen, the basement membrane, activated platelets, or high molecular weight kininogen, it converts to 12A. 12A then converts factor 11 to 11A, which in turn converts 9 to 9A. Factor 9A is the first factor we run into that requires a cofactor to operate. That cofactor is factor 8A, made of course from factor 8. I'm going to write our cofactors here in blue to make this a little easier to read. Finally, factor 9A and its cofactor 8A leads us to factor 10, and that's our common pathway. The intrinsic pathway is best monitored by a lab test partial thromboplastin time, or PTT. This test is initiated by the addition of phospholipids and an activator substance that together trick factor 12 into being activated, and therefore initiates the intrinsic pathway that can be measured for how long the blood takes to clot. The common thread in both PT and PTT is that calcium is required for both the intrinsic and extrinsic pathway to function. This calcium must be added to the tube before the tests are run. Calcium must be added because when blood is collected, oxalate is added to bind the calcium that is already in the blood and prevent coagulation before the blood reaches the lab. So our last major section is the common pathway. This begins with the conversion of factor 10 to 10A, and like factor 9, factor 10A requires a cofactor to function. This cofactor is factor 5A, which comes from, yep, you guessed it, factor 5. Together, these guys convert factor 2, which you would better know as what? That's prothrombin. So factor 2 goes to factor 2A, aka prothrombin to thrombin. Once thrombin is activated, it begins to break down fibrinogen into fibrin monomers, and this is where the money is because fibrin monomers will aggregate in the presence of calcium to produce the framework of all our clots. Thrombin also has a second job, and that's to activate all of our cofactors. So if you look back to where I've drawn our straight lines from 5 to 5A and from 8 to 8A, that's where thrombin acts. This provides positive feedback to really amplify and rev up the coagulation process. Factor 13 is activated by thrombin as well, and its job is to further stabilize the fibrin mesh network. It's located down here, and we'll draw it with another straight line. So everything we've discussed so far regarding the extrinsic, intrinsic, and common pathways is related to creating a blood clot. However, once we've created a clot, how are we going to break it down? The breakdown pathway starts with prekallikrein, which is activated by factor 12A, to form kallikrein. Kallikrein is the guy who's really looking to the future in this whole process. While all of the other factors are working to form a clot, kallikrein is thinking about clot breakdown and the possibility of infection from whatever type of injury this was. Kallikrein functions first to enhance inflammation. It does this when it converts high molecular weight kininogen to bradykinin. Bradykinin then begins a kinin cascade that increases vasodilation, vessel permeability, and pain, all of which should be familiar signs of inflammation. Think back to rubor, chylor, doulor, and tumor. Kallikrein also converts plasminogen to plasmin, and plasmin helps to activate C3 to C3A, which begins the complement cascade for fighting infections and inducing inflammation. Second, kallikrein starts thinking about breaking this clot down. If other factors were left to their own devices, the whole limb would become one big clot. The clot breakdown aspect also starts via the cascade that converts plasminogen to plasmin. Plasmin then functions to break down the fibrin mesh network into fibrin degradation products. Even if clot formation is desirable at a particular location, it is important to have some functioning plasmin around to ensure that the clot growth doesn't continue indefinitely. In addition to plasmin, what is another very important mediator of anticoagulation? That would be antithrombin, which mostly acts on thrombin and factor 10A, although it acts on several other factors to a lesser degree. Heparin is a drug that potentiates antithrombin and therefore has an anticoagulative effect. There are some serious clinical consequences to having a deficiency in any of the factors that we've been discussing. That makes this a very high-yield topic for your boards. Here's an example of a test question for these clinical consequences. What is the most common type of hemophilia? Well, hemophilias are just a genetic disorder that impair the body's ability to clot. The most common of these is hemophilia A, or a factor 8 deficiency. Hemophilia B, or factor 9 deficiency, is a less common hemophilia. We will discuss both of these in greater detail in pathology section, but it is important for you to know which is the most common because I have personally seen the exam test this idea in a style of a clinical vignette. Not all of the USMLE questions have to be a triple jump, complicated 3-paragraph question, but some can be a very simplistic, straightforward, which of these is the most common. Back to our topic, another important point is that factors 2, 7, 9, and 10 are produced by the liver in an inactive form and are activated in a vitamin K dependent process. Be sure to note that the majority of factor 8 is not made in the liver and is in fact made in the endothelial cells throughout the body. Vitamin K is also used in the synthesis of protein C and S. Vitamin K is almost certain to be on your boards, and it can show up in a variety of ways. One way you might see this on your boards is that deficiencies in vitamin K, or pharmacologic inactivation of vitamin K, leads to a decrease in what factors? Again, this would be 2, 7, 9, and 10. This promotes increased bleeding, but if a patient has a bleeding problem that does not correct with the administration of intramuscular vitamin K, be sure to consider liver failure. These factors can be listed in the answer choices or be given in the question stem, and I would recommend knowing them verbatim. Lastly, we briefly mentioned that calcium played a vital role in coagulation, but we didn't go into its specific role. Calcium is vital in several reactions in the cascade, but it can seem quite difficult to know which reactions require calcium. If you've memorized the framework we've drawn here, there's a simple memory trick we can use to assist us in knowing which steps require calcium. If you look at our diagram, each step within one reaction of factor 10 requires calcium. The factor 10 to 10A reactions itself require calcium, no matter if you're coming from the intrinsic or extrinsic system. As does the 2 to 2A step just below this reaction, and both steps above, 7 to 7a in the extrinsic, and 9 to 9a in the intrinsic. Quite simple, actually. One last memory trick. Do you recall any other links between the reactions that I just called out? Well, the reactions 2, 7, 9, and 10 are all the same reactions that also require vitamin K. Don't forget the creation of a fibrin mesh network also requires calcium. As you've gathered by now, some factors promote coagulation and some suppress it. Vitamin K, as we've discussed, is important for coagulation factor maturation. Vitamin K must also be activated before it can function. What enzyme works to activate vitamin K, and what drug acts against this enzyme? That would be the epoxide reductase enzyme that activates vitamin K, and the drug warfarin that inhibits this enzyme, thus blocking activation of vitamin K and preventing maturation of factors 2, 7, 9, 10, and proteins C and S. So basically warfarin works as an anticoagulant by inhibiting vitamin K activation. I like to remember warfarin's functions with the mnemonic WEPT. W for warfarin, E for the extrinsic system where it has its major function, and PT for the test used to monitor for warfarin effectiveness or toxicity by looking at the function of the now suppressed extrinsic pathway. Enteric bacteria is an important source of vitamin K for all humans. Neonates lack this enteric flora, and thus they must be supplemented with vitamin K at birth. How would a neonate with no neonatal care present? Well, they would present with diffuse bleeding as a result of factor 2, 7, 9, and 10 deficiency. Similarly, patients who are on prolonged oral antibiotics may kill off their enteric gut flora. This can also lead to a vitamin K deficiency and present with bleeding. There are three main methods of anticoagulation for the body: antithrombin, protein C and S, and plasmin. We already mentioned antithrombin and plasmin, but we will review them here again. Antithrombin mostly acts on thrombin and factor 10A, although it also acts on several other factors to a lesser degree. Antithrombin is potentiated or greatly enhanced by heparin. Proteins C and S work together to cleave and inactivate factors 5A and 8A. Notice that these are the same cofactors that are also activated by thrombin. By cleaving these factors, with proteins C and S, the body is unable to convert 10 to 10A and 2 to 2A, which effectively halts coagulation in the common pathway. Patients who have a factor V Leiden mutation have a factor V variant that is resistant to the activated protein C cleavage. A common source of confusion is that some people wrongly think that a mutation in factor V means that you do not have a functional factor V. This is actually the opposite of the true effect. This mutation means that you can't shut down factor V, which acts like you have too much factor V and leads to excessive clotting. So what classical clinical picture would you expect in a patient with a factor V Leiden mutation? Well, patients will present with a DVT or pulmonary embolism and are often surprisingly young for their condition and lack other risk factors for increased coagulation like smoking or oral contraceptives. We'll touch on this again when we talk about coagulation disorders. But be sure to remember that a young person with a DVT or PE and no other risk factors in your question stem will trigger you to think of a factor V Leiden mutation. Lastly, we're going to talk about the plasminogen pathway. An enzyme known as tissue plasminogen activator, or TPA for short, is what directly activates plasminogen to plasmin. Plasmin then cleaves the fibrin mesh, releasing split products and D-dimers. This is what makes TPA an important medication in the treatments of patients who actually present with clots, like we see in strokes and heart attacks. This class of medication is known as thrombolytics. Here's a quick flash quiz for us. What is the most common hypercoagulability disorder in people of Caucasian descent? That is factor V Leiden. Some of these most common questions become very important for USMLE writers, and this is one of those. The exam likes to harp on this particular hypercoagulability disorder because 5% of the white population is heterozygous for factor V Leiden, and 1% is homozygous for the mutation. To compound this fact, the heterozygotes have a 10% lifetime risk of developing a DVT. You should consider this a greatly increased risk during your exam questions on hypercoagulation.